To present this topic, Parkinson's disease related dementia, we have Dr. David Beversdorf with us. He's a graduate of Indiana School of Medicine, finished his residency in Dartmouth Hitchcock Medical Center, and did the Cognitive Neurology Fellowship in University of Florida. Dr. Beversdorf is a professor, and he's associated with many departments, including neurology at MU. He does a lot of research, does a lot of work on autism. He has a huge list of publications in very, very big journals. So without any further delay, welcome Dr. Beversdorf.
Dr. G set me up perfectly. It really makes the presentation go a lot easier because he was so thorough in his covering of not only Parkinson's disease, but the spectrum of other issues also implicated with Parkinson's disease. But I'm going to talk about one in particular. I'm going to focus on dementia associated with Parkinson's disease. But in that case, I'm also going to be talking about Lewy body dementia, which is a very, very closely related condition. And we really need to be much more aware of it because, well, you all seen this guy. He died very recently with Lewy body dementia, as it turns out. And there are a lot of the issues that he struggled with will overlap with Parkinsonian dementia as well. And usually HIPAA violation concerns disallow you to find out the details of understanding of some celebrity's case. But in his case, his wife wrote an article about what he had gone through, which was a really, really, really gracious service on her part to help people understand what goes on with Parkinsonian dementias, including Lewy body dementia. The symptoms that she listed included constipation, very, very common across the board, insomnia, that can occur, intermittent tremor, of course, that is something very common. Anxiety can go either way, memory impairment, of course, delusions, hallucinations. Interestingly, it was not clear that he was having delusions or hallucinations, but she thinks that he was having them and not admitting to them because he knew that they were not things he should be having and was very disturbed by them. And bradykinesia, slowness of movement. So you can see this also is instructive that the individual features of this are sometimes a little bit variable from person to person. Not everybody's going to have anxiety, not everybody's going to have insomnia, but a lot of these are very, very common. And one thing that was unusual is how exquisitely aware he was of the decline that he was facing, which doesn't always occur. And this, on a baseline of a depressive history, certainly put him at risk, and he ended up killing himself, which actually is not as elevated in Lewy body dementia as one might guess from just his case, but it's certainly something to be aware of. So when we are looking into dementia in general, a couple of general features are worthy of note. First off, in the clinic, we really, really need someone else there to provide the history. So if somebody's worried about Parkinsonian dementia in a patient, they definitely should have a family member, or if there is no family member, a neighbor or somebody that knows the patient well, because if the patient is coming from memory trouble, they're not going to remember all the features of it. And so it really, really is important. And what are we wondering? Well, what are the first signs? And for Parkinsonian dementia, that's very relevant. And what's the time course of issues? Is this rapidly progressive, or is this more slow in its development? What are the neurocognitive signs? Are there mood changes associated with this? Are there gait changes, which of course you would see in Parkinson's disease, and the urinary control issues? And really one of the most important things that we ask about is home safety and activities of daily living. Are they driving? And is that a really good idea? Are they managing their own medications? Is that a good idea? Are they handling their own finances? Is that going to work out well? Are they fixing meals for themselves? Are they at risk of turning on the stove and leaving it on and burning down the house? Are they, if they're more severe, are they at risk for wandering off? And are they able to, in the later stages, dress and feed themselves and groom themselves adequately and keep up around the house? All these things are perhaps as important as anything else when concerning a patient with dementia, and also the caregiver, how much stress they're under, because caregiver stress is actually a research model for stress. So always you want to assess, is the patient safe, and does the person who is helping to care for them have the support they need? A very, very important issue, and that's where help from both the Parkinson's societies and the Alzheimer's associations come into play. Past medical history and medications. Are there any medications that might be making things worse? If for some reason somebody is on an antipsychotic, I would certainly want to know about it, because that blocks dopamine, and that's something we'd really, really want to be careful with in a Parkinsonian dementia, which I'll get to later. Social history, was substance abuse a contributor here? Educational level, certainly if there is a distinguished scholar in English or something coming in who's just brilliant, the slightest decline in any test score on language would really raise my concern, as opposed to somebody who maybe had a baseline of dyslexia. You would expect them not to have the perfect score on some things because that's their baseline. Family support is critical, and also that may determine, what the social situation will be. If they have multiple family members around that can help care for them, they may be able to stay home a lot longer than if they have one very, very overburdened, beleaguered spouse, or in fact nobody at all. And family history, of course, gets to whether it's one of those less common genetic variants. What are we looking on a physical examination and then in the dementia assessment? First thing I'm looking for is anything that can cause a superimposed delirium. For example, is there a urinary tract infection? Little bladder tenderness and fever suggest that maybe. Of course, we're looking for Parkinsonian features, and of course that's the feature of concern in today's evaluation, talking about Parkinson's. Choreiform movements, if one is looking at, say, Huntington's disease, those are little dance-like erratic movements people have. Especially, but people who have who are a little bit too high on their levodopa also have things like this. I'm sure some of you have probably known people who encounter that. I certainly have myself seen that. Frontal release signs and focal neurological signs, looking for strokes. And when we're doing a dementia evaluation, of course, we're looking for subcortical and cortical. So we're looking for the extrapyramidal motor signs, pseudobulbar signs, which usually come with more vascular issues, which is like the pseudobulbar crying, and where people don't have, they just burst out into tears. It's a little bit less common with a Parkinsonian dementia, but other extrapyramidal syndromes it does. Hypophonia and dysarthria, again, soft speaking, slow movement, and a couple other cognitive features that are classically associated with Parkinsonian dementia are things we're looking for. But if somebody comes in with Parkinson's and superimposed dementia, you're already seeing that, and that's a little bit less of a mystery. So atypical Parkinsonian syndromes are a mixed bag. I won't go into too much detail because Dr. G covered them quite well. Parkinson's disease, cognitive changes occur in about 40%. And it's subcortical and early on. There's difficulty maintaining or shifting set. What they're focusing on, or they can have trouble focusing, they can have trouble shifting focus from one to the other. I had one extremely intelligent Parkinsonian dementia patient tell me, you know what, I'm having trouble changing if I'm working on the computer, shifting to something else. And in fact, research shows that is exactly one of the early features. And of course, that's not dementia. It's just one of the cognitive changes that occurs with loss of dopamine, and in fact is responsive to dopamine as well. Depression is unusually common in the Parkinson's population, so that's something to watch out for to see how it contributes as well. Cortical basal degeneration is worthy of mention here briefly because it's a little more recently defined, and it's very curious. It's asymmetric onset. So one hand will start showing it before the other. So they have difficulty, they have rigidity that starts on one side more than the other. That kind of sounds like Parkinson's so far. But they also have apraxia, difficulty with learned motor tasks in the simplest description. In fact, one patient, their initial presenting sign of cortical basal degeneration was that they were a dentist and they could no longer use their tools. So it can be quite impactful. Alien hand sign and myoclonus things that come with this. So their hand might just do something. So what did you do with your hand? I don't know what you're talking about. Or just did that. I don't know. And then jerking of the hand. So that's a less common syndrome, but it's something to be aware of as somebody showing those signs. And of course, diffuse Lewy body dementia is when the dementing process comes with the same time as the Parkinsonian features, which is how it's distinguished from this Parkinsonian dementia. First you have the Parkinson's disease, later on you develop the cognitive troubles. They come on together, and it comes on with visual hallucinations, fluctuating course, and sometimes it's much more rapid, and balance changes are common too. The pathology I won't go into, Dr. G covered that nicely, but suffice it to say that instead of just in the deep structures, these Lewy bodies in Parkinsonian dementias and Lewy body dementia are spread throughout the brain, which is part of what causes the trouble. So there have been numerous criteria proposed to define the Lewy body portion of this, and this neuropsychological features are also being defined. And it is the second or third most common form of dementia. And I think the second or third all depends on who you're lumping into one category. If you lump in people with multi-infarct dementia and any other vascular features together, and your clinic has a lot of stroke patients, maybe they'll lean towards the vascular. But if you lump in Lewy body and all the Parkinsonian dementias, and your clinic has a lot of Parkinsonian patients, those two fighting it out for 2 or 3. So it's a very, very significant issue taken together, even in a dementia clinic, looking at the overall population. And they have a couple of other interesting features that develop with Lewy body dementia and can occur later in Parkinsonian dementia. And that's the degeneration of the nucleus basalis of Meinert. And that's the source neurons, that's the nucleus from which the cholinergic neurons project. Acetylcholine is one of the chemical messengers. Dr. G talked a lot about dopamine being one of them. There are many others. Acetylcholine is one that's very, very involved in focused attention and is critical in memory, and it's what's first in Alzheimer's disease. So, but you also do lose that in Lewy body dementia and in Parkinsonian dementias, and then also you have damage to the locus ceruleus, and that's where norepinephrine comes from. Norepinephrine is critical in arousal, in fact, your fight or flight reflex, but if it's shut down too much, they actually have REM behavior disorder that seems to be related to that as well. So multiple systems are affected, not just the dopamine system. There's a consensus report that has come out for diagnosis of Lewy body dementia so that you can identify what that is and then look at how it contrasts with Parkinsonian dementia. The full range of cognitive features have been noted. There's this disproportionate loss of attentional function, so reaction time, and word fluency, which isn't terribly shocking because the bradiphrenia, the slowing of thinking, is occurring with the Parkinsonian syndrome. The figure copying, visuospatial functioning for Lewy body dementia is affected very early. And executive function, frontal sort of being able to plan out the day and arrange your thoughts in a much more structured manner is affected as well. And this is not as surprising because the frontal lobes interact heavily with the deep subcortical structures that are being impacted in Parkinson's disease itself. Now here are the criteria. You can't read them very well, but it suffices to say that this is where there's simultaneous onset of the dementia with features that include hallucinations, fluctuating cognition, with attention and alertness being affected, the REM behavior disorder. Basically, REM behavior disorder is normally when you have rapid eye movements, your body is paralyzed. You don't move. Your eyes are moving rapidly. But in Parkinson's disease with dementia and in Lewy body dementia, this can be lost, and you can thrash out and kick during sleep, which is sometimes such a significant issue that the spouse can no longer sleep with them because they're worried about getting hit when they're thrashing around. There are a lot of the other features of Parkinsonism, of course, would occur with this, and supportive features include super sensitivity to antipsychotics, which I will talk about later. So drugs that control hallucinations and block dopamine can be a real problem in these patients. And that, unfortunately, that's something that often happens because they're hallucinating for the Lewy body patients, and that's a real, and they end up getting put on that, and it's not good. There's also repeated falls that can occur because balance disturbance. They can even become episodes of unresponsiveness can even occur, which is the extreme form of the loss of the fluctuating cognition, and they get lightheadedness and other issues as well. There are a few studies, the reduced dopamine transporter uptake in the basal ganglia can occur with this like it does with Parkinson's disease. Parkinsonian dementia would show the same thing, but that's usually something that's more of a mystery for Lewy body dementia. And also you can demonstrate the REM behavior disorder on sleep studies, and also there's a cardiac study that looks at the neurotransmitter difficulties. And so the criteria include 2 or more of the core clinical features, or 1 plus one of those biomarker features of Lewy body dementia. And the distinguishing feature between Lewy body dementia and Parkinsonian dementia is that Parkinsonian dementia, the Parkinson's disease, precedes the cognitive decline, quite simply. So why is this so important? Why is this a special talk? Well, the severity of the reaction to antipsychotics is a big issue. And it's enough of a big issue that in those latest diagnostic criteria, it was actually listed as a diagnostic criteria that doesn't go well for them. I alluded to that earlier. You have significant dopamine dysfunction. So but they're hallucinating. What do you do for hallucinations? Antipsychotics. So you try to give them an antipsychotic, it blocks more dopamine. Not a good thing. They can really have a very, very severe reaction. Motor and cognitive both, very significant decline can occur. And they're even sensitive to some of the newer atypical neuroleptics, where they were brought on board to try to minimize the features of the motor features with the older neuroleptics, the older antipsychotics like risperidone and olanzapine. And they're also occasionally more sensitive in Lewy body dementia to the psychiatric side effects of dopaminergic agonists. Again, that's not something you'd want to hide away from, but it's something just to be watchful for. Parkinson's disease with dementia is a little less likely because they're probably already on those medications. And they're very, very sensitive to anticholinergics. The patients that get this anticholinergics will sometimes get it because they're going on a trip and a sea cruise. You get the scopolamine patch to try to control the seasickness, and they'll do that. Don't do that. That's a big problem. Sometimes Parkinson's patients take anticholinergics early in the course of their condition to help with some of the symptoms. If dementia is present, don't do that. Sometimes if a Lewy body patient has a balance disturbance, somebody may go, well, maybe it's vertigo, and you give an anticholinergic for that. Don't do that. It's a significant problem for these patients. And on the other hand, they respond very well to cholinergic agonists. So in the original studies, when I mentioned earlier that acetylcholine is the main chemical messenger, the most affected in Alzheimer's disease. Again, like everything else, a whole bunch of things are affected, but acetylcholine's most affected. So with Parkinson's disease as the model, where you replace dopamine, and very ironically, Robin Williams played the role of a character in a book. It played in the movie Awakenings, where they actually were giving Parkinson's disease to post-encephalitic patients with Parkinsonian syndrome, which it's a weird irony there. And he ends up getting Lewy Body disease. But nonetheless, that model was out there. And so, hey, Parkinson's disease responds well to dopamine. Let's see if Alzheimer's disease responds well to acetylcholine drugs. Well, there are a lot of acetylcholine drugs that are out there, but they had a lot of GI toxicity. And eventually they came up with some that had still GI toxicity, but less, that they're using nowadays. But the first one that they studied was Tacrin. And what they had a subset of patients that responded. It's not even used anymore because it's too tough on the tummy, and we have better options. But the first patients in this study in England, they tracked the ones that responded really, really well. There's a subset that responded really, really well, and they looked at them post-mortem. Every gosh darn one of them had Lewy body dementia pathologically after they had passed on. So this certainly inspired quite a bit of study, and they looked at rivastigmine. There was a big study looking at one of the cholinesterase inhibitors that blocks the breakdown of acetylcholine to allow the acetylcholine to hang around the synapse longer and augment acetylcholine function, and it was a very significant benefit. The other agents, donepezil and galantamine, have been studied as well for both Parkinsonian dementia and Lewy body dementia. We were actually the first to do donepezil and Lewy body dementia. It was a small study. We used the consortium criteria that was available back then. What I showed you is version 4. This was version 1. Back then it's a little simpler. They didn't have the PET scan data. They didn't have all those things. Dementia with Parkinsonian features, plus either visual hallucinations or prominent waxing, waning, and middle status. We looked at memory. We looked at overall function. We looked at Parkinsonian performance, the spatial battery, and functional activities of daily living. And it's a randomized trial, just a 4-week, just a crossover trial, just putting on a few weeks. And my clinical experience was that the response was rapid enough that we could get away with that short of a trial. And it was a 4-week washout and a 12-week block of a trial. Not 4 weeks, sorry. The 4 weeks is the washout. The trial was 12 weeks. We gave just 5 milligrams of donepezil to see how it worked, not even going to the full dose, and did have improvements in overall cognitive performance and a trend towards improvement in activities of daily living. So there have been other larger studies supporting rivastigmine. We were the first to show this. For donepezil, others have done larger studies since then. They've been reviewed in a number of articles one can look at. So donepezil and rivastigmine have a ton of data. There's less data out for galantamine, but it also looks favorable. Memantine for Lewy body disease is less impactful. It's a little more debatable. And Parkinsonian drugs, of course, can be used with a little bit of caution to make sure that the hallucinations don't get worse. And modafinil and other stimulants can be considered if there is an arousal, if they have hypoarousal, they're not aroused enough to help wake them up and focus a little bit more due to the norepinephrine dysfunction. For Parkinsonian dementia, the evidence is even stronger, actually. They actually have 2 Cochrane database reviews that have come out, which Lewy body doesn't even have, to my knowledge. And the latest one was in 2012. The Cochrane database review is basically a review article that does this big compendium of all the data out in the literature and does a massive review. They've now done it twice for Parkinsonian dementias. And all 3 of those agents I mentioned, the cholinesterase inhibitors, are shown to be helpful. And memantine may or may not be helpful, but it's less of an impact. And there's also other studies that have reviewed this since then in 2014. Both help the global impression of change, but memantine did not help cognition, but the cholinesterase inhibitors did. So that's. I actually had one patient with Lewy body when I was a fellow, and I was training in Florida, and he had mild decline, classic Lewy body, but pretty mild. We put him on cholinesterase inhibitors because even before these studies, we knew it'd probably be worthwhile knowing the pathology. And he was a snowbird, so he went back to New Jersey for the summer. We saw him again the next year, and his doctor had said, "You're fine. Why the heck are you taking this drug?" And took him off of it, and he was much, much worse. So this is a very relevant thing to consider treating in Parkinsonian dementias. Some people do respond quite well. But on the other side of this is the sensitivity to anticholinergics and to anti-dopamine drugs is so significant of an issue that if I have a patient that I think has Lewy body dementia, I actually give them a letter to carry around with them that says, I have Lewy body dementia, or my dad or my mom has Lewy body dementia. Please do not give an anticholinergic or an anti-dopaminergic without calling me first, because of the sensitivity issue. The anticholinergic can cause a major cognitive decline. The antidopaminergic can cause cognitive and motor decline. So we certainly do not want to instigate either of those. It's even a diagnostic feature, the supersensitivity to these issues. And unfortunately, because of the symptoms they have, one might consider those symptoms for someone else. If you had someone else with hallucinations or someone else with imbalance, it might cross someone's, oh, let's try one of these to help it in a Lewy body dementia patient, and in a Parkinsonian dementia patient, you don't want to do that. So I think I've tried to share with you why we need to be much more aware of that. Again, the medical issue is critical, drugs to avoid, drugs that might help. We have a long ways to go, but the evidence at this point is really pretty strong out there. We do have some biomarkers out there, and they're very closely related to Parkinson's disease. And finally, social support and activities of daily living and home safety are things that need to be front and center considerations. Get support. It's okay. It's the right thing to do. Okay. Is insight into hallucinations a typical feature of Parkinsonian dementia or Lewy body dementia? The hallucinations are a little more typical of the classic Lewy body dementia, for what that's worth. It's variable. I think we strongly suspect that that was the case for Robin Williams, but usually not. You know, but some people do. Some people are aware. I know that I see. They're usually visual, so they're seeing kids out in the yard or something like that. So. In fact, it's almost exclusively visual. And usually you have to convince them not to be aware, not to be concerned with it. And if they're mild and they're just kids running around and it doesn't provide a particularly problematic issue for them, I think you can actually try to avoid medication. But if they're severe and intrusive and cause major trouble, that might change that picture. But usually they're not completely aware that they aren't real. If a doctor had recommended open heart surgery, there are complications related to Parkinson's disease. Well, Parkinson's disease itself, you have one of the big issues is continuation of medication, and I would want one of the Parkinson's specialists to interact with the cardiothoracic surgeon to find a way of maintaining administration, if you can, of the medication. But as far as the dementia side of things, there's going to be a tremendously elevated risk of further cognitive impact of the surgery, because that's true for any type of dementia. That's a consideration for a Parkinsonian patient with dementia. And in fact, if you have an elective surgery and the dementia is far enough along, you might even think about whether or not to do it. Of course, the cardiac surgery isn't always elective, so that's a tough one. But as far as the Parkinson's disease, you'll want to have the Parkinsonian specialist be very, very involved with the case to see if there's a need to maintain some sort of continuous infusion or something to help with this. But that's something that folks like Dr. G would need to be interacting with the surgeon on. With Parkinson's disease, oh, here, somebody else rewrote it. So good. With Parkinson's disease, our children at risk. Dr. G alluded to that. There's a small elevation of risk. There's a small set of cases that are familial, but it's much less so than most other conditions. It's much less so than Alzheimer's disease, for which there is some familial preponderance. So that's good news. Now, external, internal, and environmental influences, that's something, my specialty is more the Alzheimer's disease area and the cognitive areas. But there is a lot of evidence that's growing that certain types of environmental features are associated with Parkinson's disease, but it's a very, very big data set that's out there. We know there was like some discussion of certain insecticides. It's a work in progress to get a good picture on that, because it takes a huge population to be studied in order to answer those questions. So I think for most environmental factors, the jury's still out, but keep watching that space because it's an evolving literature. There are other drugs for cognitive impairment. Exelon is actually one of them. You mentioned oral patch cause irregular blood pressure and low pulse rate. Yes, basically all we have are the cholinesterase inhibitors, but Exelon is not the only. Exelon is the rivastigmine I mentioned. That's the first one that was studied, but I don't really see that it's much different. If one might tolerate galantamine or donepezil, if they don't tolerate the Exelon. Exelon is a little tougher from the gastrointestinal standpoint as well, except for the patches, which is ironically the easiest from a gastrointestinal. But that's been explored for both Lewy body dementia and dementia with Parkinson's disease. So any of the cholinesterase inhibitors have that benefit, not just the Exelon, or rivastigmine is the generic name, but but we don't have anything outside of that drug category. Executive function seems to be a huge loss. Is it a forerunner of dementia? This is 3 post-it notes. I'm trying to see. Same handwriting, or is it? Will dementia limit the patient socially? Parkinson's patient drugs help with that. What would a caregiver do if they see signs of dementia? Who should they call or see? Well, I'll start with the last one first. Get a hold of if you're seeing signs of dementia, get a hold of your physician, ask for a referral. And the Parkinson's specialist may be so there's Parkinson's clinic and then there's Alzheimer's clinic. If the primary concern is dementia, either one could be appropriate. The Parkinson's specialist is going to be quite familiar with the dementia the dementia implications of Parkinson's disease, and of course the dementia clinic as well. But alert your clinician to get a referral, because that would be quite appropriate. Will it limit a patient socially? Will drugs help with that? Yes, it will limit socially. Any cognitive decline can do that. The motor features in Parkinson's is going to physically limit socially as well. The drugs may help a little bit with that, but the evidence is less clear. There's certainly evidence of helping with memory and cognition, a little bit of evidence of help with activities of daily living. The social domain actually is much less explored, but it probably would go along with the social domain, I would strongly suspect, because that's another high-level thing that is just like activities of daily living is kind of the byproduct of all your different aspects of cognition. Your social function is as well. So that I would strongly suspect that they would go along together. And executive function is a huge loss. Is it a forerunner of dementia? That's a really good question, actually. It may well be. So people who are showing those subtle cognitive features related to executive dysfunction, that one patient that I described a long time ago who had who described to me his difficulty with set shifting or attention shifting. He never did develop dementia in the time that I was there, but that was in training days, so I did move on. So it may or may not, but certainly it would alert you to want to watch for it. Dementia, of course, means a more global cognitive decline, not just one single feature. Dementia is defined by the loss of functional activity of daily living skills. So if you have just executive dysfunction and you're still able to manage, you would not have dementia, but it certainly would raise one's concern to watch for it. Newsletters promoting techniques of memory recovery by pills. There are a lot of people selling things, and the problem is they're doing it without data, although they claim they're doing it with data. You get the situations where somebody claims to have a cure, and you say, could you show me the data? And they go, I don't care about that, I just want to help my patients. Well, those people are proclaiming they're trying to take your money by saying that, because they are not wanting to share the data, they're just wanting to cash in on the people that come to them. If they really wanted to help people, they would share the data and let us all know. Now, there are things that people are looking into that may help, and with the memory issue, I mean, there are a lot of things that might help. The data is still evolving. We do know that for, say, Alzheimer's disease, the Mediterranean diet decreases the risk of developing Alzheimer's disease. We know that omega-3 fatty acids have similar evidence. The problem is that it's a bit of a tricky issue, because you really need a large population. When you give these cholinesterase inhibitors, you're taking people who have dementia and seeing if you can help it a little bit. Most of these other medications, if they really are doing anything, would be preventative through antioxidant pathways, preventing degeneration. So it takes a huge study in order to track people that are at risk to see if they in fact do develop it. So it's a harder study to do. They do it in animal models and they get a lot of answers like that. So we do have a nice database of things that look really promising in animal models, but it's hard, but the clinical trial phase is a bit backlogged, and it's a good question. But the people that claim they already have the answer, I'm very suspicious of. And they certainly haven't shared the data with me to be able to look at that. I actually track that issue quite closely because we are doing a trial for elderberry juice and mild cognitive impairment, trying to translate one of these agents that looks promising due to its antioxidant effect. I am not going to profit from elderberry juice. You can go to whatever store and get it. So I'll lay that one out right there. I'm not pocketing anything off this. I just want to see if we can find something that help. But that's how you should do it. And people are doing that. But the ones that are selling their pills on TV are not those people. And I would just really like to see their data before I say anything about it. And I haven't in most cases. Can REM behavior disorder be improved, or sometimes patients achieve remission? Well, remission's tricky, because with Lewy Body Dementia, you can get significant improvements with your cholinesterase inhibitor if you're one of those lucky good responders. And with pharmacotherapy, I do believe that does help the RIM behavior as well, but it can be very tricky. And I think, Dr. Balu, you may be talking a little bit about this in your talk, so I will leave that to you beyond that. But it can be responsive to the therapies we do. We're coming along nicely in the questions. This is some good questions here. My husband had an odor, oh wow, long before he was diagnosed with PD. I have not heard of that, but it's an interesting question. My grandmother told me about her doctor could walk in, she worked for a doctor, so it wasn't like she just saw a doctor, she worked for a doctor. And he could walk in and smell a patient and say, "You'd be right about what they have." And that's like the ultimate extreme of the physical examination sophistication. And with all of our tests and bells and whistles and scans and stuff, I think we've lost a little bit of that. I've always been a fancier of the old neurological examination. And the weird thing is like for smell, that's, there could be something there, but I don't know about it, but let me tell you a little story. There is, the microbiome is kind of a hot topic. You may have heard of it. And so we do know that there are more microorganisms in your body than there are cells in your body of your own. And and they're beginning to find that it interacts very heavily with the brain. And another issue I've been closely tracking because of the research. It's very, very involved with the stress pathway, and they've actually been looking at giving certain bacterial subtypes to offset anxiety in some people. It's quite interesting. Now, if you look at neurological diseases, one would sit and think that Parkinson's disease would be screaming that this is something relevant. In fact, I called an animal lab Parkinson's model person and said, and proposed that they talk to this because I had a colleague at MU who was doing microbiome work and said, you guys got to talk because 20 years, 10 years before Parkinson's disease, you have constipation. That might be important. I mean, if you think there's one neurological disease that has an important GI piece, Parkinson's just kind of jumps in your face. And so the whole odor thing may relate to microbiome issues because certainly those have an odd smell. So the answer to that question is I don't know, but I ain't going to say you're wrong. How about that? So there's a lot of interesting stuff going on. Why delusions and hallucinations? Delusions and hallucinations are due to the degeneration of multiple systems. So the acetylcholine and the adrenergic systems put together. And the good news is, while they don't respond, you don't want to give them antidopaminergics, and if you do, they're going to be like super cautiously used, focusing on only the ones that have no motor features at all. But they do respond some to the cholinesterase inhibitors, but it is a very vexing issue, and you do get it a little bit with Alzheimer's disease, but it's way more prominent with Lewy body dementia. Where can we get a list of anticholinergics and antidopaminergics? The list is long. You could get them online, but the problem is that they're long enough that I don't specify what they are for the simple reason that the person giving you the antidopaminergic and anticholinergics is going to be a doctor, and he will be able to recognize which ones are which. So that's why I do it that way. But there's a whole bunch of them. Some of them are actually, some of the antidopaminergics are actually for tummy use. So it's not just antipsychotics that are given for that purpose. So it's too long of a list to just spout out, but you can look online and find a list of them that should be reasonably comprehensive with a reliable medical source. He will not, somebody will not take recommended dosage of medication. What can he expect? I think that's something you want to take up with your physician, and try to counsel them on the importance of taking the proper doses of medication. It varies. Some people, by skipping the medication, they simply will not get the benefit of it and have more severe Parkinsonian or cognitive features. What tests are needed to determine Parkinson's dementia? Again, just like Parkinson's disease, it's a clinical diagnosis, and we basically are monitoring cognitive performance. And so we do some brief cognitive screen, and that's really how we determine that there is dementia superimposed on Parkinson's disease. So there's no specific test for that. One could look at Alzheimer's related scans, but we already know that the very treatment approach we're going to take for the Alzheimer's disease is what we're going to be doing anyway. So typically we're just doing cognitive tests. It varies how long I test them. If somebody's super mild, it can be once a year. Less so, it's once every 6 months. If somebody's having rapid decline, I'll do it whenever we feel like we need to do it. Dementia and surgery. What should I watch for? What can I do to minimize the effect beyond putting the neurologist in the plan? What's known about long-term consequences? So surgery in general is risky if it's something that can be done with local and the person not be sedated less so. That's an option, if provided they can be cooperative with that procedure. That will decrease the risk. There's no real way around the fact that the anesthetics will increase the risk of decline. There's not really a lot we can do with that, except for if the surgery is absolutely necessary, be aware of that and be very supportive, because when some people come off the medication, they may be combative, and it may be very difficult, or they may just be confused for a lot longer. There is no complete way around it. It's just a tricky issue. But every now and then I have a patient that absolutely has to have some surgery, and they do come through it pretty well. So it's not a foregone conclusion it'll be bad. It's just be prepared, it could be worse. And is seizures part of Parkinson's? Not to my knowledge, it's not. There's a slight increased risk with Alzheimer's disease, but it's very slight. And with Parkinson's disease, I have not actually seen anybody that had it that didn't already have didn't already have the seizures. So I have not heard of that being associated with Parkinson's disease. And I think that's all the questions.